Good morning. I'm Dr. Flynn, standing in here for Dr. Gabriele Jasper. We're at the Jasper Spine Institute show. If you have any questions, please feel free to call us and ask us what we want to talk about. But we're going to give a topic to start off with. Let's talk about why, when people come to practice, we ask so many questions and so much stuff going on.
Yeah.
The reason is that pain has a multifactorial cause. And defining the root cause is sometimes very difficult because one cause could block another cause, and then another cause. You have like 10 different things causing your pain. And you get rid of one at a time. People think that, well, this injection for me, but I still have pain. Well, we got rid of part of your pain, but not all your pain. It's also diagnostic. We need to know that if we do a simple injection and your pain goes away, why do further surgery? Why do anything else? If you're pain-free, even though your x-rays, MRIs may look horrible, as mine do, you just need to know that, we'll do what you need when you need it, not ahead of time. There's no such thing as preemptive surgery, or preemptive blocks, or preemptive medication. That's ridiculous.
Yeah.
And what I like about Dr. Jasper is that he really follows the rules of first do no harm to his patients.
Yeah.
He has his patients.
That's the Hippocratic Oath right there. It's number one.
Yeah, no, but none of them just follow it. It's sometimes called hypocritical oath,
Right.
And we see it all the time.
Yeah.
I was talking to Philip Jasper, Gabe's son, the other day about this one guy who has an automobile accident. Patient automobile accident, older lady, automobile accident, Medicare age, but she had auto pay. First thing the guy did was put a spinal cord stimulator trial in it, like one of the most expensive things you can do. Didn't work, but blew through for PIP money. And
that spinal cord stimulator stuff that Dr. Jasper always said, that's like your last ditch thing.
Yeah.
Like you've tried everything else, and so they throw the stimulator in, and at least that gives you a little bit of relief. But
sometimes when you get injury, like particularly after surgery or compress the spinal cord, the nerve roots gets damaged, you get neuropathic pain. You have to send another impulse in there to block that constant pain going to the brain. And that's when it works really well. I mean, superbly well. We know that when we do a diagnostic test, you first put it as trial syndrome, to take a percutaneous electrode, put into an epidural needle, advance the location to block the nerves for that pain. And the patient's awake, which happened that part in doing it and talking to him. You turn it up, turn it down. And you modulate the frequencies, how fast it is, how strong it is.
And then the patients can control it from a phone.
Yeah, new ones can. Yeah. Back in the old days, it'll dial like a cigarette box,
Right.
We get now it's control from film, but they've advanced it quite a bit, so it does work pretty well what's needed. But if you don't block the original source of pain, for example, someone's got acute pain, they got a bone spur, herniated disc, or something compressed in the nerve, or a cyst in the spine. If you don't get rid of that, the pain's gonna be there constantly. You can't block it.
Yeah,
you don't get over it. And they try that sometimes with people, and just
because people are desperate for that one and done procedure. Like I come in, you do some magical spell on me, and that's it. I don't have to worry about nothing. I can walk out pain-free. It don't work like that.
Yeah, I wish it was that easy, but it's not. And I was online with different things you can do as a physician, just to online stuff. And one of the things doing surveys as a conservative, non-interventional pain doctor. I'm thinking, well, what the hell is that? Narcotics? It's like that is, but they push that because it's pushed by big pharma. Big pharmacy, it pushes all that nonsense. And in Dr. Jasper's practice, and I agree with him 100%, is that use narcotics only for like 5 days post-op is a painful procedure.
Yeah,
which is very rare. I mean, like I did anesthesia the other day, and not a patient. When one patient requires some fentanyl post-op, because she had a herniated, not herniated disc, but a fractured spine, and that put the kyphoplasty, put the cement in, she's still in pain. So you gave her like 2 cc's of fentanyl. That was it. And this is pharmaceutical grade, not Chinese fentanyl.
Right.
And she was fine. She gave her 1,000 milligrams of Tylenol first, and then did it work. She gave the fentanyl, but that was the whole day of like 30 some patients.
Right.
I did all the anesthesia with this propofol, which is twilight anesthesia. Knock them out, feel great, and wake up. They say, "Oh, I slept for an hour." I said, "Actually, you're asleep for 6 minutes."
Yeah.
Best night's sleep I'd ever as well.
Because that stuff's great. Like it makes it so you don't have to remember all the stuff you don't want to remember. Yeah.
And the patients like it. They want it. Sometimes you inject it, you feel a little burning in the arm, the IV, but it goes away real quickly. And I just tell patients, "Hey, tell me you feel that metal taste in the back of your throat," which is what I know when I had propofol. I felt and went out. And they tried to talking to me, raw, raw, raw. and they're out. So that's it. Ready to go, Gabe. Ready with Dr. Jasper.
Yeah.
But yeah, it's fun. And we're talking about when you come to the office and you get seen by the nurses, seen by Dr. Jasper, seen by myself. We'll ask you 1,000 questions, sometimes over and over again, because we want to get to the root of it. Because sometimes it's hard for patients to explain what their pain is. A lot of times, the variation between is your pain positional, meaning is your pain there when you're laying in bed flat? Is your pain there when you're sitting up? Is your pain there when you're walking? Does your pain go away when you're leaning forward? And all this gives clues to possible causes of the pain. Is the pain below your knee, meaning lower nerve roots, L4, pain above your thigh, L3, pain at your sacrum area, L2, S1.
Right.
So,
Which I mean, it sounds easy, but that's something I've always found fascinating is that just from a conversation, you can pretty much isolate exactly where the pain is just from where the patient tells you it's radiating,
right.
and what levels will need to work on. And that's even before an MRI.
I know. I started medicine.
Yeah.
There was no CAT scan yet. There was no MRI yet, I
Yeah.
think it was 19 branching medicine first for the first 8 years. And it was challenging, but we did it. We got it through it.
Yeah.
Patients coming in now, if the doctor throws the MRI, says, "Oh, you got this problem here," bullshit.
Right.
Because my MRI was horrible. My functionality, great. And that's over years of time, exercise, working on doing things. And I learned that from a patient who was 90 years old, lived in Wachovia, Florida. It was an orange grove grower. He had no disc in his spine. Lumbar spine had no all like one on top of the other, like a little tiny sliver of space for the. He could bend over and touch his toes without pain. It's a mesmerizing thing. Just goes beyond what I thought happened before. So for that patient, I said, let's forget your MRI, see if you feel, do the examinations, if I can provoke the pain. There's certain things like if you lean forward a little bit and twist like 45 degrees and kind of bend that way, you're compressing, you're doing that. You're bending over. Let's see this here, this right there. So you're like this, standing up straight and get it right in the camera. There we go.
Yeah.
As you bend over, you twerk it and you twist, you're putting pressure on this joint space right here. That's called a facet joint.
Right.
Which you typically call like arthritis of spine and stuff right there. Those two come together. That's a space. So we provoke that. And if we identify what level is that, by the contrast it with the X-ray and the MRI scan, we'll have a better idea of what we want to do. So for that, you can do what's called a medial branch block, which means you block the nerve that comes off the spinal cord, off the nerve root, and goes right to this joint space.
Yeah.
Right there.
Right there.
Yeah. And generally, there's two nerves. Well, generally, there's two nerves going there, one above and below it at the site. Those nerves are going to block two levels. So if you're pain at the L4, you're going to block L5, L4, and L3. So we do at least 3 levels at a time. And that's what's just anesthetic with the local short-acting anesthetic. And then repeat it when insurance protocols down with a long-acting anesthetic. This is where patients have to be patient because we have to do what we're allowed to do by the insurance protocols unless you're paying cash. But no one really pays cash for that stuff. So covered by Medicare and insurance. So it's the way to go. But it takes patients know they got to do it. Wait a week or 2 weeks, do the second block, wait 2 weeks. Then you get back and do radio frequency. And what that is when you put a needle right onto the nerve location. And it's marked by a little spot right there. And you put radio frequency, it's like a heat wave, like 80 degrees centigrade for about 90 seconds.
Yeah, it burns the nerve for about, at 80 degrees.
Yeah.
I've had it multiple times. It's, I got to tell you something. It is a saving grace when you have arthritis in your spine. I have it. In fact, I'm rolling out of the bed hurting, so I'm going to need another one soon. So that's in my future, is a radio frequency ablation, and it's nothing. It's nothing. As from a patient's point of view, you're laying there. If you got trained doctors like this guy and Dr. Jasper, I mean, you don't even feel it. You don't need anesthesia. You don't need any shots. It's easy, that one.
Yeah, I would say in Jasper Spine Institute, we do anesthesia maybe 30% of the patients for the more painful patients, more painful procedures we're doing. Except, for example, if we're doing a simple epidural steroid injection, we're simply got a really tight space with a nerve axis right here to be able to swallow like this big thing. See, this one here is rather large. Here's smaller.
Yeah.
So in that case,
that one's all swollen.
So it's really hard to get the needle in there and get in position. So it may hurt the patient because you inject it, decreases the volume of the space, which is a closed space right here.
Yeah.
The nerve exits. And it causes pain. It's severe pain. It's like someone stabbing you with a fork or a knife.
Oh, believe me, I know.
So do I.
Yeah.
So if that's the case, maybe next time the patient comes back, we'll do it under propofol anesthesia, which is just like the milk of amnesia, we call it, because it's knocks you don't know recall what's going on.
Right.
And then you do the block and the pain goes away. And you
Mm.
see how long it goes away for. For some patients, maybe 3 months, 6 months. That's the case, that's all you do. Even though things look bad there, if that gives you relief.
If I get like a kyphoplasty, I like that second week after, that's when it really hits and you got no pain. Is on that second week. And they last me for about a year.
Well,
You know, a real good year though. Even maybe more. And then I come in for what I call a tune-up, you
Right.
know, and Dr. Jasper gives me my tune-up and then I'm back. So that's the importance. Like you find doctors like you guys, you got to stick with that. You know, I get spotted by the patients when they're when they're sitting in the exam rooms and walking past because he's the TV guy, um, and then I go in and sit with him, and and I ask him what you in for, and I try to put them at ease. I tell them from my experience from a patient's experience, and I had a nice couple this week that flagged me down, and I reassured them. It's like an extra service I do for everybody. I'm just a marketing guy, but I've been through their stories are my stories. You know what I mean?
Right, right.
Yeah, and it's important for them to know that this is the place. Follow the process. There is one. There is a process because it's not one and done.
Right. Well, patients with pain for the kyphoplasty, their pain is rather unique. It's there 24/7 in almost every position they're in.
Yeah.
Doesn't go away, leaning forward, bending over, side to side, rolling over. It's always there. And that's because the nerve, which is this one here shows the nerve inside the vertebral body. And in those cases, most time in MRI, you'll see something. For example, you see a crushed vertebrae or broken, this is called the end plate here. That could be collapsed down from osteoporosis or injury. Or it could just be what's called motor changes, meaning like the nerves, the bone itself is starting to grow really fast inside there. So you have these cells of bone growth, which impinge and cause irritation, inflammation against this nerve. So if someone doesn't have collapse of the bone, but just has that kind of pain, that's usually kind of hard to tell. With a collapsed bone, it's easy to tell right away. You got to go do the kyphoplasty.
Yeah.
Well, the other procedure, which is similar to kyphoplasty, you go in through the pedicle, which is this structure right here, right this space here going down.
Right.
And you put in a radio frequency probe in there that kills the spinal vertebral nerve inside the vertebrae and blocks the pain. So, but with the cement, with kyphoplasty, that goes in there. The cement itself, the alkalinity of it, and also the heat of it generates, kills the nerve and blocks the pain. But nerves do unfortunately grow back.
They grow back, yeah.
And that's where you have to have recurrence and pain goes back.
And then you need another tune-up.
Right, right.
Yeah.
So if it's really obvious, because this the patient's presentation, the history compares with the X-ray and MRIs, and that's what you got to do first. A lot of times, it's not that easy.
Yeah.
So maybe I may have like pain, just a twist and bend, like the facet joint pain, or the pain shooting at a leg, nerve radiculopathy, radicular pain, or they have pain from narrowing the spinal canal, spondylosis pain, found more with bending over, leaning forward. Like people go to the grocery cart, store, use a grocery cart to walk in the store.
Yeah, and that's only one description. If you're just bending over, if you're walking and you're already looking for your next chair to sit down in, that was me at one point. And I was walking with my granddad at the time, and I just, it's like we're walking, and thank God there was a bench every couple of ways. Because then I'd be really walking towards that bench, nowhere else, so I can sit down and get some relief.
Yeah, that was me back in 2022. I was going skiing and snowboarding, and I could do that because you're skiing, you're kind of bent a little bit forward. Snowboarding, you bent a little bit forward. And I had a colleague who I skied with at the ski club, and I snowboarded with, and he had scoliosis, he had a nerve impingement. He could walk like 20 yards, had to stop. He could snowboard all day, bent over, going really fast. He's really good at it. He got that nerve impingement taken care of. He had a cyst growing on the nerve root, got it taken out. He had scoliosis, his pain was gone. So it was pretty amazing.
Was it you that told me you got your pain primarily from skiing?
No.
It wasn't you?
I had pain walking the ski lift, but not sitting down.
I gotcha.
When I was standing up walking there, I had pain. I had spinal stenosis, and so that was the main cause of my pain. But I had prior back surgeries, prior auto accidents, which really kind of sucks because I'm driving to work one day and someone pulls out in front of me, I T-bone them and see it happening and brace for it and herniate disc in my neck and lower back. Lower back one didn't herniate like 3 or 4 years later.
Yeah.
That thing rear-ended coming off of Highway 50 in Annapolis, going to the Annapolis Academy, Naval Academy, and someone just ran at 50 miles an hour, texting, going off the
Of
ramp.
course, yeah.
Usual crap,
Yeah.
So, but yeah, I saw Dr. Jasper in 2022 in January, and he did steroid injection, did a mild procedure. Me, that's another interesting procedure,
Yeah.
which we happen to have this device right here. So, got all the toys here.
We do, yeah.
So this looks impressive. It looks difficult, but what it is, it's really amazing that we can go in to the spinal canal space.
Right.
Let's get this right for the camera. There we go.
Yeah.
Right here. And there's a space here where the ligaments are going to be right under here. Let me take this off. So this is your spinal canal.
Yeah.
And ligaments go in the back here. It's called the spinal posterior ligament. That tissue can grow inside there and compress downward on the nerve roots inside.
Is that the ligamentum flavum?
Yes.
Yeah.
Yes. Compress downward here. So what we're able to do is go inside there, and the bone can overgrow as well. We'll decide to chip off some of the bone here percutaneously, which means just through a small incision of skin.
Yeah.
And then we chip some bone off and chip some of that away, and then we go back in afterwards, and we use the scooping action to pull the stuff out.
Yeah.
Let me get that right there. Yeah, right. So right in the space there.
Pulls out all the material that might be
between the ligament and the bone.
Mm.
And it's amazing because I had that done in January, and I was able to ski 3 months, ski and snowboard 3 months without pain until it got so bad that something came back and grew back, and I knew I needed to have the Minuteman put in.
Yeah.
So I came back in April and had it done. If I had it my way, I would have done it in January, and Gabe probably too. But Michelle is a great nurse.
So wait, you have a spacer in you right now?
Yeah.
That's amazing. So we have an actual doctor who knows all about this stuff, who's actually got what we talk about.
Yeah.
And that's wow. And you feel
It's great.
Yeah.
I mean, the recovery period from it, I talked to patients about it too. I talked to a gentleman yesterday who needs to have one. And I said, the first part you have to think about is that your bone's been compressed together, ligaments are all compressed together and shortened. And when all of a sudden you separate them with a spacer, which goes right in this space here.
Yeah.
Get that right. My big finger. So there we go. And make it open like that. So now where the nerves are exiting right here,
yeah,
that opening is enlarged, which is my big problem. The opening was there, it's so small and tight, when it was made bigger, the pain went away. But this you have for about, I'm guessing maybe a week, 2 weeks, some tightness sensation across the back, but it's not sharp pain. It's kind of like more like aching pain.
right.
You work out too hard to gym that day or something, you feel tightness there, then it goes away. But you have to give time for the space to sit in place. It takes about, I always tell patients 3 months. Don't do any vigorous activity. So I didn't do anything vigorous. Of course, didn't snowboard or anything. Just deal with it.
Yeah. Hey Tyler, how you doing? Top of the morning to you too, buddy. That's my broski from another Moski.
Howard, Tyler.
Yeah.
Good to see you. Good to hear from you.
I married he and his wife.
Did you really?
Yeah.
Wonderful. Great couple.
Yeah,
Great kids too.
I got ordained and I'm their chaplain.
Wonderful. Yeah, we went fishing yesterday.
Oh, did you really?
It was cold. Oh
was it really?
It was so cold, so windy. He's like, what the heck? We did that about a half hour. We went back to Dr. Jasper's house and had a nice Good Friday dinner.
Oh, that's
good.
nice,
Yeah,
man.
cool.
That's nice.
Yeah.
Yeah, he's all the family stuff over there is fantastic. I've enjoyed going over doing tomatoes and doing, a bunch of other stuff. They're all great people, really great people.
I know, and it translates into his office.
Yeah,
Office, like one
it
big
does.
family. You don't see that very often in patients and staff and employees.
We're a family, I
Yeah.
feel like, and every once in a blue moon, like, I don't know if it's the patient, like he got done with the patients earlier or what. We have a lunch hour where we all get to sit down at the table together, and that's just so much fun because we're talking about just anything and it brings us closer. Yeah, I love that place. I have because of what they've done for me as well. I have a personal, bone in that, but yeah, Michelle, our office manager, Philip, Gabriella, Dawn, this is just like on the exam side, really, you know, and then we've got like Jatana and Nancy and everybody over on the surgical
So
side.
yep.
Yeah, we got a happy family. Suzanne, you know.
Yeah. My practice was very similar to that. I have my same office manager. We're still friends 34 years later. We worked together for 26 years, 20 years in
Wow.
practice, the same person. Then her sister joined the group 3 or 4 years later. And most of my employees were there a minimum of 15 years,
Mm,
which is nice to see that.
yeah. I mean, you do have to sometimes, you know, weed out the ones that don't fit, you know.
Right, right.
And those situations always end poorly. Like a couple of nurses we've had just, oh God.
Well,
Yeah.
sometimes like I had a few nurses who were using me for a stepping stone. And I understand that. They want to try something different, go in the hospital, to some kind of more intensive work. I had one nurse whose husband was in the Coast Guard, Nicole Griffiths. She was one of our best nurses. She's friends, years later. And she got with the program and learned really well, knew the patients loved her. And she always called the patients Buttercup. This big Delta Force guys come in. She says, "Hey, Buttercup, what do today?"
They must love it though.
Yeah.
I mean, that's fun.
It's not captain, or lieutenant colonel, or commander, or admiral. It's Buttercup.
Yeah.
So,
Yeah.
it was great. I missed that. So I worked with Gabe. I enjoyed that. Same kind of camaraderie.
Yeah. We have a good time though. We have a good laugh all the time.
Well, his staff has followed his guidelines. They really are well trained. When they ask nurses questions, they almost know what's going to go happen, what's going to do next.
Yeah.
The protocol, call it the protocol, but it's based upon what you say, what you present with, what your complaints are, how you did in the last procedure. And what I like the most is that this follow up, when you do like this example, a simple transfemoral, which means going from the side here.
Mm-hmm.
It's right in the camera. It's like working backwards. Right here.
Yeah.
There we go. Putting a steroid in there, the needle. That's done generally with patients under local. Injecting steroids and to see how they do, and they right immediately once the anesthetic is on board, the lidocaine or marcaine on board. In the post-op recovery, they diagnose how much pain you have. 80% relief, great.
Yeah.
Then call back 2 weeks later again. How much? To 10%, not so good. 50%, good.
Yeah.
If you tolerate it, it's doing well for you, then stick with it and don't do anything.
Yeah.
Go back and see me in 2 or 3 months, or sooner if you have pain reoccurs. And that standard of care is not often found in medicine.
Oh, I know. Yeah.
It's really,
When you get your doctor, like you, Dr. Jasper, and you sit down with the patients, you talk with them, you educate them about what's going on with them. So it's not guesswork. See, like you get a lot of patients that come in and they're just, I don't want to hear any of this. Just you do what you got to do, and then that's it, right? But no, you gotta know this as well as you do, and that's important. But it's a relationship you're building because of their pain, trying to eliminate it.
right.
Yeah.
Well, the ultimate choice is the patient's choice. It's the informed consent. So our job is to inform you of what we can do, what we're going to do for you this time or next time, what the process will be. And sometimes, we can't spell out the 20 different things we can do to the patient because that just totally confuses them. So we'll say, well, first we're going to do this to address this issue and see if it makes the pain go away. If not, then we'll do something else. Then they come back in and say, okay, so you still have pain, so we'll do something further and go to the next step. Or you may have like had a Minuteman put in place, steroid injections put in place, you still have back pain, you have arthritis. So you go back to the first thing we talked about, which was the set joint blocks with the medial branch blocks of rate of frequency. That may take arthritis and pain may go away. Or maybe like you had with the kyphoplasty or the intercept rate of frequency of the esophageal nerve may go away. So it's a constant progress. So both Dr. Jasper and I like the fact that it's puzzle solving every day. The patients get to be a part.
It was like detective work every day. Yeah.
The patients get to be a part of the process. Staff's part of the process. And they enjoy it. They really take pride in the work and the fact that the patients are doing well.
Yeah.
And patient testimonials better. I mean, you're a marketing guy, but you as a marketing guy and doing testimonials is phenomenal. And that's like the best of the best.
Oh, I did this great testimonial. Did I even post it yet? No, I haven't posted it yet. I'm actually going to use it in the new TV commercials I'm working on. This woman was so lovely. And she turned out to be Philip and Gabriella, Dr. Jasper's kids' school teacher.
Oh, really?
Yeah. And oh man, what the stories she was telling me. She's writing a book. what a wonderful woman. I felt it's like sometimes you meet these patients, and you just feel good that you met them, and she's that kind of woman. Um, but I walked away glad that I met this lady and had some time to sit down with her and talk with her. But yeah, that testimonial you'll be seeing soon. I'll post it probably Monday, and it'll be on your TV sets.
Oh, cool.
Yeah, as well.
Years ago, when I was in my practice is called Spine Diagnostics Intervention Center in Tampa, Florida.
Mm.
I had a patient who knew someone at the Fox News Network, local Fox Network, and he had really bad back pain. He told his friend, who told a friend that he's having this thing done for the radio frequency, which was new back in the early 90s. And he said, hey, my friend's family is part of the Fox thing. They want to come by and bring this camera and do his things. Do you have a problem? That's not a problem with that. I said, let's make the last case of the day because the OR won't be so clean after that. So we'll just, have to clean it up. So brought him in there, filmed him getting a slight anesthetic, getting the radio frequencies done, and filmed him recovery, how he was feeling afterwards and later on. And they posted it. I get 5 o'clock news. My phone was off the hook for the next hour. It was crazy. It's like, I couldn't believe it. Didn't cost me a dime. It's just crazy, but it shot me up to the top of the stars in Tampa for the pain practice.
Oh, that's great. Yeah. That's great.
But,
it's
been such an evolving field. It's like some are retired in 2020, and they came back this past year to work with Dr. Jasper and help out and do things and get re-educated. And the newer stuff has just been saving grace for patients. I mean, the things we do for the elderly population.
All of these new innovations that have come out and all of that. It's a marvel. I mean, even with something like kyphoplasty.
Oh, yeah.
Right? The innovations that came out in that made the procedure so much more safer to do with less risk, Now I've seen it, I've filmed it. You can see Dr. Jasper perform it on our YouTube channel. Yeah, he's got that up there. And there was a 90+ woman that came in and she was telling me that her husband had passed away, and she's like on a stretcher, and I'm sitting down next to her just talking to her, and I'm not filming anything, I'm just talking with her, and she says they took me to the funeral. I guess it was the funeral people that did it, but they threw her in a van with no chairs, and she's bouncing around in the van, going to and from the and she got a compression fracture in her vertebra, vertebral body, and and so here she is. She's in the most pain of her life. I saw her go in. That's when I started filming the procedure. And then when she was done, she got right up and she felt like $1 million. Like, that is a miracle right there. You want your one and done?
That's one of them.
Compression fractures, you can get your one and done.
That's very true. And that's like the no-brainer. They come in, you might see a compression fracture, which is this bone here being compressed and fractured from any portion.
Because it's like gravel and they crunches together while you're moving, and that. If you're younger, you get a chance to heal it up on its own, but it will take time. But when you're older, it's a nightmare. That's like that, and that's the proverbial, oh, he broke his back.
Right. That's the true.
Yeah.
Yeah, that's true.
Yeah.
A lot of times it happens in the lower thoracic spine, the lumbar spine. But it's one of the things where the relief is instantaneous for patients. I would say that one and the small stenosis, the Minuteman procedure. One gentleman I did back in February, he grew probably a half inch. We put a big screw in him to make him elevate his height. He's like 6'3" to begin with. He stood up straight first time. He was like pain-free. I couldn't believe it. Of course, some is still for the local anesthetic, but that's usually local is mainly blocking the incisional pain. But the device itself, when it opens and releases pressure off the nerves, that pain goes away. That's really important. That's really important.
Yeah.
And the big thing is, like, for compression fractures, if the patients mistakenly in their 90s, they get given opioids. Opioids slow down your bowel empty time. They can cause people to have pancreatitis because they get slow bowel movements and the sphincters don't open up correctly, and they get pancreatitis develops on them. They can suppress the respirations. So it's very dangerous.
Yeah.
And it doesn't block the pain. That pain is so intense. You have to almost be either comatose or in pain.
Yeah.
And opioid is not the way to go.
And pain pills, they're a Band-Aid and a very temporary one. Okay. Before I met the doc, I went to many these so-called pain doctors in Brick, where they give you that series of 3, send you to physical therapy and back, but and then they chuck pain pills at you,
Right.
right? And yeah, you take them, but then you start taking more because it's not working as best as it did before when you originally started taking them. So you take more and you take more and you take more. Then the doctors all like, oh, this guy's only out for these pills and stuff. Because sometimes that's it. Sometimes people are out for those pills. All right. And they're running scams, going to like 10 different doctors at the same
no.
time, but then and it ruins it for genuine people who just want to stop suffering pain. I didn't want to take pills. I wanted somebody like Dr. Jasper to come along and do it. And thank God I found him.
Yeah, yeah.
Yeah.
Yeah, the pain pill epidemic, it's kind of, well, it's getting less, but now we have fentanyl, which kind of is weird because it kills the population they're serving.
Yeah.
So the Chinese fentanyl. But the pain pill epidemic was a problem. When I was in ASIP, was the American Society for Interventional Pain Physicians. In 2003, we went to Washington, D.C. And we were canvassing all the congressmen's places to talk to them about passing this bill. And what it was is called the National All-Schedule Prescription Electronic Recording Act, NASPR. And the idea is you come to me as a patient, and I rate you opioids for whatever reason.
Uh-huh.
You go to the pharmacist records it so it knows that you're the patient, that's the pharmacist that gave it, and I'm the doctor prescribed it. It gets recorded. It goes in the big data networks. You can see, if it's kept up to date, which if Florida initially wasn't, then Florida didn't pass it until 2009. So it took 6 years they passed. I don't know why. We passed it to Congress in 2003. So I had a DA agent come to my office because I was running a workers' comp clinic for a while, and they kept on pushing me to push oxycodone and Somicum. So I'm not going to push that shit.
Oh yeah.
So the guy came to inspect. I said, I shut it down. He goes, why? I had it for like 8 months. He goes, why'd you shut it down? I said, because they're pushing drugs. I don't want to make money off people in drugs. He goes, God, you're unique. I said, what do you mean? He goes, across the street from your office down the road about a mile.
Oh yeah.
They have a pill mill where they're pushing 100, 200 scripts a day.
Yeah.
$200 a pop. They had a guy in the parking lot with a computer and a printer, printing MRI scans.
I was going to say all that's missing is some sort of back alley deal where there's a handshake. Yeah.
So it's funny. So we're talking. That's just corrupt. Is in jail? Goes, no, they get off. They kill people. But when someone dies of OxyContin overdose, they also have alcohol in their system or something else in their system.
Yeah.
You can't truly say that's the one thing that caused the death. So the doctor walks. So he goes, we don't sponsor you for the board of medicine. I said, well, I love that. This is my little fiefdom here. I take all my special forces guys, all my patients. They love me. We love each other. We take care of each other. And it's a nice, safe practice. And they know it. And they come to me. I discourage those people from coming. You can see them from a mile away. They come in there, like 2 or 3 at a time. I'm from Harrisburg, Kentucky. What are you doing here in Tampa, Florida?
Yeah. No, we got these great people at our desk that screen.
Yeah.
And you don't even know you're being screened, and if they get whiff that you're there for pills, it's not gonna happen. No, not at our place.
No, I know. Yeah. I love that because Dr. Jackson had the same key with that. When I was an emergency medicine doctor, so we're talking 81 to 88 or so, 89. I mean, rules were different back then. A little black logbook in the ER desk, and we keep track. Mrs. Jones came for her shot of Demerol today. Today I gave her something else, like Compazine or something, and Benadryl. Next guy says, I gave her normal saline, got the same effect. Her husband gets off work at 5. She comes at 4:30 every day. So finally we started to give her saline. And we had the pharmacist in town that we could write placebo backwards.
Placebos, yeah.
We write it backwards. And prescribe give it something. They go, this little red pill for pharmacy. Darvocet, it's just like a red pill, nothing in it. Then I had a patient who was a work comp patient that I detoxed on a detox protocol, methadone. And I wound up giving her with methadone and Benadryl, and I kept cutting out the methadone. So for years, she's taken a cherry elixir. The same effect. And then she found out she got mad. I said, what are you mad for? You didn't harm yourself. Nothing happens. Your brain convinced yourself that you're getting pain relief, and it worked. And that's the placebo effect.
Yeah.
But now you can't.
So now it's tricked you into having a positive affect.
Exactly.
Right. So now you're like, but then when you find out, it all swells back because it's pain. There's a lot of the same receptors in your brain that register pain, also register happiness,
Right.
So yeah, I mean it's it's a hell of a change.
Yeah.
Yeah.
Well, that's why. So now you can't play the tricks. You have to be straightforward, and honest. Which in a setting like this, we can do all the time because the time to spend with the patient. But a busy ER, if you get a code coming next, and someone wants their pain pills, whatever, you just can't. You
Yeah,
just
you
got to
can't
deal
do
with it.
that.
So,
Yeah.
but nowadays, it's the relationship between you and your doctor that makes a big difference. If you have to trust the doctor, says you don't need this, you got to trust him. If you're hooked on opioids, then that's a problem. You can't help you.
Right.
But if you want to get off the opioids, we can help you. That's something I did in my practice too. The addictionology to get people off opioids.
Yeah, and that's what I was looking for. I didn't want the pain pills anymore. I had a couple of doctors flat out tell me I was gold bricking, and I was just in it for the pills and stuff. Then I find Dr. Jasper, and he's looking at me, and he's like, you got a very considerable herniation here, like, and that was the best thing. I was looking for a doctor to tell me I wasn't crazy.
Right.
Because I'm feeling a certain way 24/7. I was crying in my sleep. The pain was that bad. Okay. And everyone I went to were like, no, here's some pills, but that, or there was this one Indian doctor, a female. I saw her once. You're faking, you know. Uh, well, you're not a very good doctor then, if that's the case. Yeah.
No. When I had my herniated disc, so I had the accident in '96 and had a big bulge sitting there at L45.
Mm.
That was with my children at a horse show in Oklahoma. And I was trying on some cowboy boots. The two tennis bending over and grinding and pulling off the boot off my foot.
Right.
I felt this shooting pain go down my leg, electric bolt down my leg. That evening, back to the hotel, I could barely get in the shower, go to the bathroom, and walk. Going home to the airport next day, I had to be wheelchair through the airport to get to the airport.
I've done that. Yeah. I've done that.
Getting the MRI scan done the following day, it was so painful. I could barely lay flat. So it's kind of shaking a lot during the scan. So it was not a great scan. I saw a colleague of mine. He goes, well, I learned this new procedure. So that back then it was the tubular discectomy, a little tiny tube put in your back.
Yeah.
That was before Joy Max came out with the endoscopic discectomy. And the guy who helped work that for Medtronic software and Danix was a doctor out of Tampa that moved to Memphis, Tennessee at Methodist Hospital. So I flew up there, and he took me in and did another MRI to get the exact location. It was a huge herniation, covered the entire canal, and got L4 and L5 nerve roots. I had foot drops from it.
Doc always said that you can herniate just by tying your shoes.
I had a patient pick up a feather pillow off the ground.
Oh, wow.
And she's legit. I said, I just a patient of mine. I said, wow, it's pretty impressive.
Yeah.
But it can happen. Just it's weak in the moment. It got torn earlier, something happens, popped out. But that pain was intense. That you cannot see nothing to take care of the pain. I had to get the surgery done for the pain.
Yeah.
And I was having my pre-op done. The anesthesiologist says, okay, dude, I'm in pain. Give me some pre-op. I had nothing for it, so I'd be clear for the doctor to tell me what's going on.
Right.
They gave me something. It was kind of funny.
I would go to the emergency room because my pain was so bad. They would give me 1,000 milligrams of Tylenol, which didn't do anything.
No.
I was just looking for somebody to do a surgery or do. Then I met this this one doctor who says, "Yeah, the science isn't there to fix you."
Sorry.
Yeah, so you're going to have to deal with this pain. And I was like, "What?" And I left that doctor thinking that's what's happening to me. That I have to.
Well, that's a bad.
I have to just deal with this. And at that point, I was already feeling dark because I'd gone 4.5 years. Stuff. Oh yeah, man. 4.5 years. I couldn't stand. I couldn't sit. I couldn't walk. So I was laying flat on my belly because it was the only comfortable position that I could without that eased up the pain. And I had like a bottle of liquor, like strong liquor on my bedside because nobody was giving me any kind of relief. So I'd be swigging it down and that, asking my family, can you please kill me? I'm done. Because the pain was just that intense. And all I'm seeing is doctors either giving me that series of 3 or telling me there's nothing we can do. So when you finally find a doctor who tells you that there's something wrong with you, you don't know what a relief that is.
I know.
Yeah.
The worst combination. If a physician is arrogant and ignorant and driven by money, that's the worst doctor.
Yeah, forget it.
You need to leave as quick as you can. Just go out the door.
That's the importance of a second, third, fourth opinion.
Right.
Yeah.
And I always tell patients, they come in, they Google things up, Google MD. I said, well, see if Google MD answers your phone at midnight or something, call. But, in my practice, the patient I had called once at 4 o'clock in the morning. It was a mistake. The answer service, someone's trying to work on a surgery schedule. They wanted to notify the staff, and the new answer service was called me at 4 o'clock in the morning. I said, okay. And I fired him. But patients would never call me. They just if I did a surgery to the patient, they'd have my cell phone number. They would call me their problem. I never got called. Make sure took care, like Dr. Jasper, everything's done ahead of time. He knows what the protocols are. The staff knows the protocol, what to do for the patients. They have everything they need and leave there taken care of. When I had my surgery with Dr. Jasper, I stayed at his house afterwards. As college, you can do that. And
I remember when you came in 2022. Yeah.
Zook was taking care of me.
Zuki's a good boy.
Yeah,
Zuki's a good boy.
That's cool. That's what we're going to talk about today.
You mentioned before the show about ivermectin and such.
Right.
Yeah.
So when COVID-19 happened and people were trying alternative treatments for it, I was at my cardiologist's office just getting a checkup and just getting things done. And he was on an international call. This is back in, I think, December of 19, or no, January 2020. And he said, here, sit on this call with me, come in the office, sit in the call. They're talking about the treatments protocols for this new virus, coronavirus, and how ivermectin works and hydroxychloroquine works and zinc and all this different stuff, and established a protocol. And that same year, they formed the Frontline COVID Care Coalition, was a group of doctors who were like using alternative medications rather than what Dr. Fauci was prescribing for people. And, it's the mainstream media attacked the doctors, attacked us.
You were, but when you say attack the doctors, doctors were losing their license to practice because they were going off of their education, their experience, and Fauci just had it rigged where no, you only get this one thing that I happen to own.
Right.
That
didn't work the last 3 tries I tried it.
Yeah. And then the left start spewing all this ugly stuff about the medicines like ivermectin. That's a horse pill. Are you kidding me? You don't give that to humans. It's stupid. You get a smaller version of it for humans. We're not swallowing horse pills.
No, I know.
But that's the same thing about when they said to when Donald Trump said, "Do you have any like bleach?" He didn't say inject everybody with bleach. He said, "Do you have something like that bleach, where you can just inject it and it clears everything out?" But the left's got to make a stupid friggin' story about it.
Well, it's all driven by money.
Yeah.
Advertising, marketing, drug companies. I had personal experience. I treated all my staff, got the protocol medication in case they got COVID.
Yeah.
One person didn't take it. She got sick. Was sick for quite a while. Family members. I had my wife's uncle was in the ER. His oxygen saturation is down like 72, which is almost time to intubate. Almost time to intubate. I told his wife, just get him out of the ER. And I hit him with ivermectin, high dose steroids, doxycycline, zinc, vitamin D3, high doses. Just followed the whole protocol. Within 10 hours, his oxygen was up above 80. With the next day, it was like 90 something. And she was like a nurse educator, so she was down to take care of it.
And all of these situations, all of these patients that did good with these medicines was never reported.
No, they blocked it.
They blocked it.
There's a doctor, a gastroenterologist, Dr. Zahn, trained at the University of Florida, had her clinic open in Malibu, California. And she was doing a FDA study on ivermectin. And 3,000 patients, one of it was a colleague of hers. He was getting sicker than shit. Started part of me, but getting really sick, about to die.
Yeah.
So she broke the double blind, which means these patients get this medication or get the placebo, and then she doesn't know which one they got, and she analyzed the patient. So this guy was about to die. She broke the protocol, see what it was. He was on the placebo. Gave him ivermectin. Within 10 hours, he was better.
That's amazing.
Not just ivermectin, the whole protocol.
But then you had like at the time President Biden hiding like all of the mono.
Oh yeah, and he got in a fight with DeSantis of Florida.
Right.
He wasn't allowed to come to Florida.
The what was it? The
monoclonal antibodies.
Yeah, monoclonal antibodies. So Biden is pretty much playing a game of kickball. He gets pissed off, takes the ball because it's his, right? And said, okay, no one's playing now, But he hid all of those monoclonal antibodies, refusing to put anything else into patients, and the people ate it up. They thought, oh, this is it, because they used the fear of a worldwide pandemic to make them think that this is it and you're going to die otherwise.
I mean, Dr. Corey, Dr. Merrick, they all took the heat for what they did, putting it forth. This lady, Dr. Zahn in California, she had the FDA try and take her down. She says, "You approved my protocol, and ivermectin is working. Well, we don't want you to do it anymore." So she finished the study and proved it was working. Then they market against her. She think it was Bill Gates marketing against her to get her, because he was also part of the money for the antiviral medications.
Yeah, and like, so it's just it's like a vicious circle. So back then it was Bill Gates, that now it's Elon Musk. It's the same old tricks. That they're because they know it works. They know that they can pull the wool over people's eyes with what they've been doing so far. It's just now our administration is showing everything up front.
Transparent. I love
that. Love it. They're so transparent. You can't say anything bad about it. Before, it was all guesswork. I mean, Biden's first 100 days, you never saw him.
No.
He hid.
The automatic pen. I think Dr. Jill was the
latest. Yeah, she was kind of the president, maybe with whisperings from Obama.
Yeah.
And but even today to this date, we don't know who the last president was, really.
No, I know a private group of people that working in the White House.
Yeah,
put the body in there.
When you got the Easter Bunny handling you, right? That I worry about that. But then of course you got guys like Vladimir Putin, right? And he sees how ridiculous this president is, and sure, he's going to invade wherever he feels like, and because he knows that president doesn't have any chops. It's just the secretary's running everything.
I know.
Yeah,
that's crazy. Any questions yet?
No. It's a slow day.
Shout the number. It's after Good Friday.
Yeah. It's a weekend, holiday weekend. But if you want to make a call, it's 732-237-4949. If you want to call us right now and ask a question. If you want to ask a question to Dr. Gregory Flynn, he's right here with us. Or if you just want to say hi, Oh, and also, guys, if you could do us a big solid and like or subscribe.
Good, yeah.
Depending upon where you are. If you're on YouTube, please subscribe. If you're on Facebook, please like our page. That way you'll get notifications for whenever we do go live. Sometimes we get some gaps in weeks because Dr. Flynn's not in town, or Dr. Jasper is off doing his extracurriculars, like racing or flying. He's a jet setter, Doc. But you'll get notifications and you'll know. Spreading the word is the most important thing, because only you can help us grow our channel. And you've done such a terrific job over the years. We get patients all the time just from this show. And even if you don't catch us live, you listen during the week, because we try to give you a little entertainment too with it all, have a laugh. But so type in a question, say hi, say hello. And me, your old pal Jeremy.
Jeremy, back to the topic, talking about the alternative uses of ivermectin. It's funny how historically they found out that it worked better around the world through epidemiological studies, where the success rate and survival rate was better in Peru or Ecuador or India after they went off the remdesivir medications and the other drugs.
Yeah,
the United States had 2,000 and something per million people dying. It was crazy. It was the exact amount that died was crazy, man.
Yeah. Well, when the bodies start stacking up, and they were,
I know.
Yeah, and I was going to say about the like if you got onto the respirator. Oh. And this is what the real the criminal thing is. We had things like ivermectin, monoclonal antibodies, all of that stuff. that could have been tried before the respirators. People thought, and I still think, you get on a respirator, that's it. You're
It's
done.
all about this.
Yeah.
The government's paying $39,000 on this respirator. When it came out, Como invested and bought like 30,000 respirators without having therapists to run them.
Yeah.
There's a good book out called What the Nurses Saw.
Ooh.
It is mind-boggling and devastating. And by this book, when you read it, basically 16% of the patients who died of COVID actually had COVID and died from COVID. The other 94% died, or 84% died of like malpractice. I mean, would it be by the pharmacies, by the nurses, by the hospital administrators? You take a pick who it was from, but they were ordering doctors. Basically, if you came in with regular pneumonia before that, you probably got antibiotics, steroids, treatments, those stuff. When COVID, you got stamp of COVID on your chart, they push you to the respirator without even Tylenol, aspirin, antibiotics.
Yeah.
You weren't being treated normally. I met the same trip I was skiing in Breckenridge, Colorado. I met a young ER doctor from Georgia. I was asking about it. He goes, "Oh, they're coming in waves, they're dying in waves." I said, "What are you doing here for him?" He goes, "Oh, we sent him up on the floor." I said, "Do you administer any treatment in the emergency room?" The first, no, we're not taught. We just sit on the floor. That's what we're told to do. I said, "You do what you're told to do?" I said, I was trained in school, always question. I tell my patients, question me, challenge me.
Look at
If I'm wrong about something, I'll be wrong about it.
the Nuremberg
exactly.
trials. It's not good enough to say I was just following orders.
No.
Yeah.
No. And that's what I'm afraid about young doctors being trained. If they can get through the fact that, all the research grants and money is coming from big pharma, big medical companies pushing this stuff. You're like, surgeons get to do surgery, they want to put in a bunch of rods and screws in your back before they do something simple.
Oh yeah.
And it'd be nice if it was like a stepwise progression across the board, but they want to make their living, make their money. That's how you do it. It's like, it's scary.
Yeah, we've had patients come in and they're with their X-rays, and it looks like they've got like two old style wrenches in there. Some of the stuff that they were using just to support back or support, was nuts back in the day. We had a patient that came in who had drywall screws.
No way.
Serious. We had the X-ray up on the wall until it faded and you can't see it anymore. But they were drywall screws that were screwed in, and I guess over the years they started unscrewing themselves, and so the pain started back up, and he comes in. That must have, and I mentioned back alley deal earlier. That's had to have been some back alley surgeon in like Bangkok or something like that. Who did that, because that's mental. They're not even medical grade, metal or anything like that. They're just drywall screws.
Yeah, I had a surgeon in Tampa who owned a metallurgy company that made screws and rods for his practice that he sold to the hospital, which to me has got to be crooked.
Yeah.
And the patient comes in, I'm doing a Fecitrin block on him, medial branch block for his arthritis. As I come around the X-ray and look on an oblique view, the screw to the pedicle is broken inside the pedicle. The pedicle's intact. So it must have been metallurgy issues. The screw just broke being put in or something. Then he had like a zigzag, like erector set. Little kids' erector sets go on the spine to the next level. And so the one side was done. So this doesn't make sense.
Right.
And so I didn't alarm the patient and tell the surgeon, I go, sue this guy, send him back to him.
Yeah.
And the guy came back with more hardware next time. Then he herniated above the hardware. He goes, "Can you take care of this? I'll take care of it for you." It's very simple. In the scope, in there, pull the disc, done. It's out. It's done.
Well, that's what we say about like major fusions and stuff. It's going to get weaker above. It's going to get weaker below. It's only a matter of time.
Right. And some people do need it. I mean, there's no question about it.
Sure. Yeah.
But it's not like we said. Like similar is not the first choice. A fusion is not the first choice unless they auto case.
And there's different kinds of, like, look at the spacer.
Yeah.
Rather than a fusion. That spacer really works, and it's kind of, you got to put some bone graft in there, right? Yeah. So in that way, it's kind of a fusion, but it's not a permanent one, and it can't be taken out, and that. So I like that. Yeah. But there are alternatives. Is my point.
Last time I was here, we talked about the Viadisc procedure, which is new since I retired.
Yeah.
It's like doing discography. I mean, you just go in through.
Now this is for people who have severe degenerative disc disease.
Exactly.
Yeah.
So this disc is really compressed, and the seeing pain. We can go in with needle right into the space, right where my big fingers in the way.
Yeah.
Right there.
Yeah.
Go inside there. The Viadisc material is made of cadavers, dead people's discs, but nucleus, and they grind it up and put
It's an
it together.
allograft, right?
Allograft, exactly.
Yeah.
But when it goes in there and the right nutrients inside the disc space, it actually grows a little bit and increases disc height. So that rather than being compressed like this, it's going to be open a bit like that.
Show the difference between see these discs you're seeing in between the vertebra. They are very thin.
Right.
Okay. So show how they naturally would be.
Well, it'd be almost like this far apart.
All right. So due to yeah, that's perfect. Due to degenerative disc disease, they shrink up like that.
Yeah.
And because of that, it closes off spaces where the nerves would travel through the neural foramina, and it crushes them. So an injection into the nucleus of that disc, strengthening up, puffing it. I see. We all know in the office. I can explain this stuff as well as Dr. Jasper.
And so can all the staff, and that's important because the patients can ask questions. A lot of times you're talking to them, it's like you go into the lecture hall and you're just inundated with new material the first day in school in lecture hall, and you're just like, oh, I can't deal with this stuff here.
Right.
The second, third time you pick it up on it. So same thing in practice. If the nurse talks to you, I talk to you, X-ray tech talks to you, Nicole, Jessica, Michelle, April talks to you. You get it, it sinks in, and it takes a while to sink in. We anticipate that. That's just known, especially for older, especially the fact you're in pain. It's hard to focus when you're in pain.
Oh yeah, yeah.
So
if you're in pain, and we get a lot of new patients, and we understand these patients have been to doctors, obviously, that have not helped them, and they've probably been to several.
Yeah.
Okay, so by the time these new patients come to us, they're not exactly happy, and they're from all the useless stuff that the other doctors did, that gets thrown on you now. And so yeah, it is important to sit there, have a conversation with them, tell them, this can work for you. There's newer things. Some doctors, they don't go further than what they already know in their wheelhouse. You know what I mean?
I know. I had a colleague. We and I were interns together at Balboa Naval Hospital, San Diego. He went neurology, and my brother needed to have prostatectomy done. I said, "You do the new Da Vinci procedure, which is robotic prostatectomy. It saves. You make a 6-day stay in the hospital at least, and major surgery, a lot of blood loss stuff.
Yeah.
With Da Vinci procedures, no blood loss. He was in the hospital 22 hours. Had it done at GW by ex-Navy doctor over there. He don't learn anything new. I said, "How do you do that? Why don't you learn new stuff?" He goes, I'm retiring. So your brain becomes like brain fog. It's like brie cheese is melted. It's like,
yeah,
you want to keep learning because it keeps you interested, keeps your ambition going, drive going. You want a doctor who wants to keep on learning and keep doing new stuff. The other one, talking about the ivermectin, I have a colleague, a friend of mine in Annapolis, who had prostate cancer. He had a prostatectomy done in his local hospital, and they went to Johns Hopkins for treatment. Had some radiation therapy in his pelvis floor. And they said, that's all we do for you. In 6 months, you'll be dead in 6 months. That was 22 years ago. He himself found a doctor down in Florida who did what's called oligo, meaning small, metastatic therapy for prostate cancer, to find where the cells are going elsewhere, and found a way through another colleague to do, it's pretty common now, back then it wasn't common, to identify with radioisotopes the prostate cancer cells throughout the body. And he would radiate each individual one. So he stayed with me like 3 months at a time on 3 different occasions where he had radiation therapy, just those sites, and blocked it. And he's also on suppressive hormone therapy. And then it came back. So now he's doing this radioisotope therapy. It costs like $25,000 a pop to get it done. Insurance is covering it. But I said to him, look at this protocol for ivermectin and zinc and different stuff along with that, and fenbendazole, which is pain cure C on the veterinary side. And people saving lives, living a long time with it. This guy Tippin, who went to MD Anderson, was in a study. It was like 7 years ago. 1,000 people in a study. He didn't want to survive. He still survived. They put online, it's called the Tippin protocol. They find that it's working with the ivermectin combination and fenbendazole for solid tumor cells. It doesn't work with much leukemia stuff, but for solid tumor cells like prostate, breast, ovarian, it's working well. And they're trying to poo-poo it because all those drugs have been on the market for a long time. Ivermectin is very safe, but they're out of what do you call it? Their trademark is done on the drugs, so they want to research it because there's no money to be made on it.
Right.
But it's all about the patient's health, and so the people doing very well on medication. So I'm sending him a whole bunch of prescriptions for the ivermectin and fenbendazole to get him started on it because he's got metastatic disease. And I said, John, what's going to hurt?
Yeah.
The doctors can be dead in 6 months, a year, want to try this, and people don't die from this medication. So it's very safe, very healthy medication.
Yeah.
So, yeah.
I mean, do you feel more freed up now that we have a different administration?
Oh God.
Yeah.
Yes.
Yeah.
Yeah.
Right.
Yeah.
That has to be said because, you know, you don't know how restrictive it was before. You know, you couldn't even talk about things.
Well, Florida, we could.
Florida, you could. Florida was like the only place in the country where, you know, you had some freedoms. You know, you were still a sovereign American. Yeah.
There's a place in Naples called Seat to Table. It's a great restaurant, market, and everything. And the
Yeah.
guy opened up during COVID, ignored all the COVID rules, come in there, no mask wearing stuff. And he was very much a Trump proponent guy. And I went there, I got a t-shirt, but the Trump hat that says Trump's right about everything.
Yeah.
The guy gave me a t-shirt. He goes, wear this shirt. It says, Make America, Florida. So,
That's
but
great.
it's like, yeah, how the freedoms you designed you should have. You're supposed to have those kind of freedoms for doctors and thinking and stuff. You know, in med school and students, I just wonder how it's going to be. If they're going to be learning new stuff. They're going to be told what the industry wants them to know.
Yeah. My son's in Harvard, and he just started yesterday, in fact, working
Wonderful.
at what's the hospital there? Mass
Mass
General. Mass General. So he just officially started working there. He has his phlebotomy license, and he's going to be looking. He's going to be seeing everything, and he's going to be learning from doctors who, yeah, they came out of the COVID years, and they saw how it sucked. I mean, a lot of them, especially the nurses, were laid off because they didn't want to take the
The shot,
vaccine
yeah.
and stuff like that, or the Francine is what we used to say on the
Francine.
radio. Yeah, getting the Francine, and so I'm very curious to see how his education and what he sees, and and how his political viewpoints form.
Yeah, my alma mater, University of South Florida, got changed to the Masonic College of Medicine. Masonic was a big car dealership guy in Tampa and donated money before and after his death. I guess he didn't die yet, but got the name of the school. But the school became very woke, extremely woke. To the point I used to teach nurse anesthetists there in the program, and director nurse at times was a patient of mine, and I took the dean's wife years ago as a patient of mine, and I was on staff as a school. I was independent doctor. It's called like the town doctors, what I was in gowns, or university doctors.
Right.
And then one student there who's follows Kentucky, and he was a nurse, and she was very open-minded about everything. I said, how's it in school? She says, I don't speak my opinion. Why not? Because they put you down for speaking your opinion. I said, why not? Why? That's how they are.
Yeah.
When I was in college, you walk across campus, of course, like Vietnam War still ending up at the time. And you speak what you're saying, have arguments with people, but you go back, have a beer and talk about it. No big deal. It's not that way now. I mean,
Yeah.
the kids don't feel like
they threatened like a Department of Truth, right? They had that woman that was singing weird songs. Remember that?
Yeah.
But and then there was no more talk about it. But then I was always saying on the radio, the best way to have a Department of Truth is not tell anybody about it.
Yes.
And just take away the freedoms that you need, and don't answer any questions, when they're asked about it. And I really think that that's what was happening. They got what they wanted anyway. They just didn't make a big deal about it. And then the American people, since we couldn't speak freely anymore, we just, what could we do but take it?
Well, all the files, the JFK files, the RFK files, the Martin Luther King files being released.
Yeah.
I saw a special on TV about JFK when he first went to Parkland Hospital. The doctors there, interviewed the doctors there, and they spoke free at this point in time. And JFK was shot first in the base of the neck because the doctor put a tracheotomy, went through this hole for the bullet. The second shot was right here in the hairline and blew out the right side of his skull.
Yeah.
When he went to Secret Service, took him back to Bethesda and stuff, they did special things. They put a different skull cap on him, a different brain inside him. Covered this up and said he was shot in the back by Oswald. Dulles, who was the CIA director at the time, Kennedy was going to fire him. Dulles headed the Warren Commission. And so it was a government hit, I'm sure.
Oh yeah, they've already said it was CIA that did it. And that's why the magic bullet, just didn't make sense. So they called it a magic bullet that could zigzag around and hit everybody, but it was multiple gunmen. It's not even a fact that Lee Harvey Oswald hit anything, if he even fired. They're saying so. The theories of grassy knolls, people hearing shots from different directions, that was all the truth. And it was the people who saw it.
Right.
The people saw the truth because it couldn't be argued about. But the government does what they do. They don't answer questions. And you're wrong, and that's that.
Well, I think what Trump is doing to make everything transparent, make people question. No,
Yeah.
you have to question your government, have to question your authorities, have to question your doctor.
Right.
Question what's happening to you, because you have the right to know and the right to be treated fairly and honestly. If someone says, "Well, I'm in charge," bullshit.
Right.
You're the patient. You're in charge of your body. You're the citizen. You're in charge of your country. That's how it should be.
Yeah. And when you go transparent, it's harder for them to make fun or to turn it or twist it around or anything like that, because it's all right there. What are you going to say? We all heard the same thing. So what are you going to say about it?
I know.
Yeah.
I know. It was a frightening time. Now it's getting more to be more of a happy time because things are changing.
Yeah. All right. Well, we're at the just past the hour.
It's been a great conversation today.
Oh yeah, we did have a great conversation, right, Greg? Yeah. So I'm hoping for more of these, because this is a blast for me. So for those of you who want to get in, call and make an appointment, let's put that up on the screen. It's 732-262-0700 to make an appointment at the Jasper Spine Institute. And for more information about Dr. Jasper and all the things we talk about on our shows, go to Jasper MD. Anything you want to say?
Yeah, I want to push 2 books.
Okay.
RFK's book, Through Anthony Fauci, great read.
I've read it. Yeah.
And then What the Nurses Saw, great read.
So what the nurses saw, and The Truth About Anthony Fauci by RFK Jr. Yeah. That one I've read, and I know that's brilliant.
Yeah.
You can see the corruption. You could see, I mean, it was mental what was going on and what was allowed and what had become normalized.
I know.
That's a word that so many words came out of that time. Harder, like disinformation, misinformation, and then, stuff like normalizing things and presentism. Yeah. Like all of these words just started to manifest, and it was all bullshit.
I mean, Dr. Fauci's an old man, but I think he should go to prison before he goes to the grave.
Yes, I agree too, 100%. All right, so this has been Dr. Gregory Flynn and your old pal Jeremy, and we're going to say
thank you.
Thank you, and have a great week, guys.